A very happy morning, everyone. So let's discuss some questions from labor modules. As inshallah, we will focus in our revision 2 days before exam on the labor problems, and we will focus on the early pregnancy problems and the subfertility, including the endometriosis. Okay, so today we will go through some of the September questions, trying to finish it inshallah quickly and solve hopefully questions from the module of labor. Okay, so while tomorrow, inshallah, we will do early pregnancy and infertility more. Okay, why? Because those are the recent guidelines that appeared, um, published by the Irish, right, Council, and you will find a lot of these scenarios in the exam. So last exam in September, you've noticed labor scenarios was more than before, right? So inshallah, you will be able to tackle it all. Okay, so as I told you, we are expecting the most recent guidelines. If there is a new questions in the exam, it will come from the 2025 updates. So here, my friends, let's see a gravida 1 para 0, which is admitted in labor with uterine activity at 39 plus 3. She had a low risk pregnancy to date. She is found to be contracting 3 in 10, and these contractions are mild and incoordinate. Abdominal examination revealed the fetus in the cephalic position with 4/5 of the fetal head palpable abdominally. Is that good? 4/5, that's mean baby is high, right? An initial vaginal examination revealed an effaced cervix, 6 cm dilated, with intact membranes, and -3 station. A repeat examination after 4 hours reveals no change. Next most appropriate step in the management is what? So if there is no change after repeat examination, that's mean what? I need to do something, right, to help. So what do you think I need to do here if there is a delay in the first stage of labor? Yes, exactly. So it will be perform amniotomy, ARM, right? And then we will repeat the examination in 2 hours, right? Good. So the good thing now that we are following the same recommendation of the NICE 2022. Okay, so here, a 26-year-old, gravida 1, para 0, at 40 plus 5 weeks of gestation, she presented to the labor ward with regular painful contractions for the past 3 hours. On examination, contracting 4 in 10, which sound like adequate contraction. And the contractions are strong. Abdominal examination reveals that the fetus in the cephalic presentation, with fetal head 3/5 palpable. Initial vaginal examination reveals an effaced cervix, 4 cm, fetal membranes intact, and the head is at -1 at the spine. No caput, no molding. The position is not defined. At 4 hours later, second examination revealed that the head remains at -1, and the cervix is still 4 cm dilated despite ongoing adequate contractions. So what do you think is the most appropriate intervention? Options are here. Yes, exactly. Okay, so, but she is 4 cm. Okay, I have to do something. If she is like 2 cm, I would say that this is latent phase, give just a painkiller, make her comfortable and wait. But now, okay, no oxytocin, right? Shall I go for cesarean section or amniotomy? So if we go to the options one by one, you will see from least one, so from E to A. Okay, I will go retrograde. Oxytocin, no. She had strong contraction. D, oxytocin, no. very early for cesarean section, and the baby is not compromised. There is amniotomy and there is amniotomy. Which one? No problem. If the head even is high, you can do a controlled amniotomy, my dear. No problem. B. Okay. So you will do amniotomy and examine in 4 hours, or amniotomy and examine in 2 hours? It is two. Okay. It is two. Amniotomy and 2 hours. Okay. So it's not B, it's A, like the previous question. Okay. A 28-year-old woman. Yes, it's whenever, Dr. Salma, whenever I have amniotomy, it will be followed by examination after 2 hours after the amniotomy. Oxytocin, examination after 4 hours of oxytocin. Of course, a continuous CTG and everything, but it will be oxytocin, next vaginal examination after 4. Okay? 28-year-old and gravida 1 para 0 at 39 weeks of gestation present to the labor ward with regular painful contraction for the past 3 hours, preceded by gush of clear fluid. On examination, she is contracting twice in 10 minutes. Abdominal examination reveals that the fetus in cephalic presentation and the fetal head 3/5 palpable. Initial vaginal examination reveals an effaced cervix, 4 cm, head at -1 to the spine. No caput, no molding. Position is not defined and there is clear liquor. At 4 hours later, second examination reveals that the head remained the same. The frequency of contraction has increased. So this scenario is very similar to the scenario above. But the only different is what? Yes, there is already, yes, rupture. Another different happened, which is the frequency of contraction has increased, right? To 5 in 10 for past 30 minutes. So here, my dears, frequency of contractions now become 5 in 10. Can I add oxytocin in this case? Can I do this? No. She already now have something that it changed. What is this? Something that already spontaneously there is an increase and improvement in the contraction. Actually, they become 5. Okay, so I can't add any extra oxytocin to this case. Okay, what I will do is I will just advise to repeat assessment. But the question here, when to repeat the assessment? This was a delay or not delay? She was 4 cm. And 4 hours later, examination same. So this is a suspected delay. So you will repeat the assessment in 2 hours. Well done. Yes, well done. So no need for cesarean section. I can't add oxytocin. So B and C is wrong. The question here is it D or E? Repeat the assessment in 2 hours or in 4 hours. Here I will do the repeat assessment in 2 hours because this is a suspected delay. Okay? I hope it's clear, inshallah. Okay. So this is another scenario, my friends. A 26-year-old gravida 2 para 1 with low-risk pregnancy, she presented at 41 weeks of gestation in spontaneous labor. She was transferred to the labor ward from birth unit as she has been pushing for 2 hours but not yet delivered. So pushing for 2 hours, shall I do something for her? Yes, sure, right? and she had a normal progress in labor to date. No CTG concern on arrival. Finding were at the following: vitals are okay, per abdominal examination less than 1/5 palpable. So already head is coming low, still not very good, but it's okay. Less than 1/5 palpable. Vaginal examination fully. Presenting part at the spine. Right occipital posterior. Caput and molding. Plus, not excessive. So what do you think I will do now? Shall I go for cesarean section because this is 2 hours pushing and there is a delay already? Or shall I do an instrumental delivery in the room? Or shall I do instrumental delivery in theater? Or wait? Or what? Yes, it will be an instrumental delivery in theater. Well,
Occipital posterior.
yes, exactly. So we will add high, it's at 0 station, right? So this is means in instrumental delivery, it will be in the theater. Well done. Yes, exactly. Well done, Dr. Amna. So here, my friends, another primate at 38 plus 6, okay, is admitted with history of abdominal pain and clear fluid vaginally for 5 hours, which is fine. This is SROM. Let's see. No other risk factor in her history. On examination, her observations normal. The pulse rate is fine, blood pressure is fine, temperature is fine. She's having regular, painful contractions, 3 in 10, and cervical dilatation is found to be 4 cm. CTG was performed due to concern, right, about the fetal heart rate on auscultation. The CTG shows a baseline fetal heart rate of 140 to 50, 150, with no other non-reassuring or abnormal features. Good? Good. So now what is the situation now? Contractions are okay, 4 cm, right? But there are concern. After this concern, okay, there was no problem in the CTG. So what I will do, when the CTG, my dear friends, started due to concern for the fetal heart rate, what should be the action?
Continuous CTG.
Yes, exactly. So you will keep the CTG, right? And this is, should be like for 20 to 30 minutes and then continue normal care, right? So this is the best. I will not do augmentation. I will not do cesarean section, okay? And I will not perform fetal blood sampling. No tocolysis is required, and this is the best available option, right? So answer is C in this case. So my friends, now let's see next question. 19-year-old Brimey admitted to the midwife-led unit at 39 with a spontaneous onset of labor at 5 cm. So, okay so far. On admission, her blood pressure 140 over 90. Pulse is 92, no problem so far. No protein in the urine and no symptoms reported of preeclampsia. She had repeat blood pressure monitoring, and after 30 minutes, her blood pressure was 140 over 90. So now, my friends, I have a lady, only thing that the blood pressure is high, and it's mild, right? Blood pressure. But this is when repeat is found the same. So what do you think? What shall I do? Reasons or causes of transfer from a midwifery unit to an obstetric-led care unit, right? Right? Okay, so this will be, yes, transfer. Well done. So indication of transfer, whenever I have in the indication of transfer, I have one of the indications, I need to contact the coordinating midwife to arrange the transfer to the obstetric late care unit. Okay, it's now a new thing that changed in the intrapartum care uh, of the Irish guideline. Okay, because now they are following the same nice guideline of the 2022. So guys, take care of such question that can come. Okay, indication of transfer. Here, choose a single best answer for the following scenario. In a 28-year-old, para 1, attend your clinic at 36 weeks of gestation for review. She had cesarean section for the pathological CTG at 8 cm in the last pregnancy 3 years ago. She is asking how she should deliver. So what do you think now? So she's coming here for counseling, right? At 36. And this is a previous VBAC. There is a pathological CTG, right? And at 8 cm. So what you will do at that time, not now. Okay? So this was because fetal distress. So what you will do now, advice? Yes, exactly. I will tell her, I'll reassure her that the success rate of the VBAC is 72 to 75. Well done. Yes. So she can attempt a VBAC because the previous cesarean was simply because of a fetal distress. So see, the scenario continues, okay? And this short scenario, as you will see in the exam, more of short scenarios, okay? The woman is now admitted at 40 weeks of gestation with regular uterine activity and clear liquor draining, and she's found to be 5 cm dilated. The woman is now admitted 5 cm dilated, regular contraction, clear liquor. What you will do for a VBAC in labor? Yes, she need a continuous monitoring, but where is the continuous monitoring option? Okay, whenever I have a delay in labor, suspected delay, and I am performing ARM, okay, rupture of the fetal membrane, I am examining after 2 hours. Okay, why? Because I am the one who have done the intervention is done by my hand, okay, because of a suspected delay. Okay, so the rule that after amniotomy, our artificial rupture of membrane, okay, to do examination in 2 hours, that's because we have done the ARM due to suspected delay. But look, my friends, here, this lady, she came with normal, right, finding. This was a spontaneous rupture at labor, and she had strong or regular uterine activity. This is a VBAC case. So I know that I need to do the necessary. She will be in the obstetric unit. She need a CTG monitoring, right? But the examination will still be for every hours, 4 hours, if everything is fine. Okay? So the examination here, my friends, should not be reassessed in 2 hours. Sounds logical, but this is not the guideline, right? So A says stop continuous electronic fetal monitoring. This option is there to deceive anybody who's not reading carefully. So, no, I should start, not stop. B, reassess in 2 hours. Why? This is not artificial rupture of membrane. So, no. Cesarean section category 1. No, no need. Ensure that the woman is still happy with the plan of VBAC. Yes, because this is the only correct option available. The fetal blood sampling is no, of course. Okay? So D is the answer. Yes, exactly. It's D. Because even if you don't know this information, that you should ensure any woman who comes for VBAC at the time of labor that she is still happy, or otherwise she changed her mind and she want to go for cesarean. Okay? Even if you don't know this information, this is only correct by exclusion. Okay? The precaution that you will take, my dear, in the VBAC, not the frequent examination. It is a CTG. Okay? And monitoring. Examination per abdomen to exclude any tender uterus. Okay? And that you will be careful, right? A midwife will review the case. If there is any red flag sign, she will go for it. Otherwise, okay, my dear, this is like normal frequency of assessment. After 2 hours, okay, she progressed to 9 cm. And the CTG has been reassuring. So everything is fine. The plan is to reassess in 1 hour, but the midwife looking after her tells you that she is now complaining of constant pain across her previous scar. Okay, so a VBAC in labor and constant pain over the scar. What do you think the problem is? Before we continue reading the scenario, it's ruptured. Yes, so see here, CTG, variable deceleration. So this is very dangerous. If variable deceleration appeared along with abdominal pain in a VBAC, this is early signs actually of rupture. And the baseline increase. Meconium staining of the liquor, and there is maternal tachycardia. So it's ruptured. Right? So you examine her and a bit of faint, and she's fetal bradycardia, and maternal blood pressure is 70/47. So what is the initial diagnosis? This is, of course, uterine rupture. Okay? That's very easy, right? Even in the exam, in your Irish exam, they will not continue all the scenarios. They will give you the first 2 lines and they ask you, what is this diagnosis? Because the Irish exam actually looking for, somebody who is able to diagnose clinically fast. Okay? Okay, so let's have a look now, okay, to our yesterday questions, okay? Or we will solve another one. Do you want to solve some of the questions? Okay. Okay. We will solve another questions. Okay. So this question I will ask you about, okay, till we have another set. At 22 years old, Primey, at 39 weeks of gestation, and she's admitted in labor with regular uterine activity. She was examined at 1 p.m. and found to be 5 cm dilated. Vertex at 2 cm above the ischial spine with intact membrane. So now I have regular uterine activity. Examined at 1 p.m. and you found 5 cm dilated. Vertex 2 cm above spine, high, intact membrane. and then you re-examined at 5 p.m., you found to be 6 cm. Okay, this is adequate or not adequate dilatation? Not, yeah, adequate. And the vertex is 1 cm above the spine with intact membrane, right? Okay, so what you will do now? Above the spine, can I still do amniotomy? Yes or no? Okay, amniotomy can be done, but not instrumental delivery. Be careful of this point, my friends. Okay, so I can perform amniotomy by controlled amniotomy, right? So you will control the head, you will support the head by your hand, right? Support also from the fundus, make sure that everything is fine and the patient is, head in place, and then you can perform the ARM, right? But now, when I tell you above spine, no instrumental delivery if she's fully dilated and you want to deliver her, and above spine, no instrumental delivery. Okay? So now, what do you think? Intact membrane, right? Vertex 1 cm above the spine with suspected delay in labor. ARM, yes, exactly. Amniotomy. Yes, so amniotomy to be done in this case. Yes, a scenario for a fully dilated, this will be a suitable scenario for assisted vaginal delivery. So a 39 years para 1 admitted to labor room in spontaneous labor, and she's fully dilated for 2 hours. Okay, so this is 39 para 1 labor room in spontaneous labor, fully dilated for 2 hours, and now examined, you find the full dilated, left occipital anterior, vertex 1 cm below spine, with plus caput, no molding. So what do you think I will do for this lady? 2 hours fully dilated. He didn't say for how long she's pushing, but 2 hours fully dilated and she's para 1, so I need to do something. What do you think? Okay, so the question here, is it in the room, the instrumental delivery, in the room or in theater? Okay. What is the thing that make you have like favoring the delivery in the room? Okay. So for good. So I will say something. Yes. So you're thinking here, my dear, okay, that the lady, she have the instrumental, yes. She have, sorry, the full dilatation, right? She's multi-gravida, right? Or yes, she's para 1. Okay. And it's occipital anterior. Okay. 1 second. I will show you, my dear friend, the decision-making algorithm of the Irish guideline. Bismillah. Okay, 1 second, just hold on, please. Bismillah. Yes, assisted vaginal birth, the Irish guideline. I know that you are waiting. I'm here, don't worry. I didn't go anywhere. Just trying to open it. Bismillah. Nothing is responding, mashallah. Okay. There is a tiny difference, my dear friends, between the two guidelines. One is the RCUG guideline and the other one is the RCPI guideline. Okay, so there's a tiny difference in this guideline that simply, okay, for the positioning of the fetal head and the choice of the place of delivery, right? Yes, this is now inshallah opening. Inshallah it will open. Okay. Yes, yes, yes. Here it is. Okay. Sorry for taking that time so long to open a file. Excuse me, guys, I'm not that fast. Okay, so look, my dear, for the decision-making algorithm here for assisted vaginal birth, okay, where to perform assisted vaginal birth. So, continue in labor room if station is at least +1. So see, my dear, here, there is a tiny difference between the two guidelines. Station is at least what? 1 plus. Yes, I have explained that in the decision making, right? No rotation or rotate easily, okay? And no features of cephalopelvic disproportion. Effective anesthesia and low probability of failure. So our case here, my dear friends, that she is +1, but there is also low probability of failure and no need for rotation. Occipital anterior +1, multigravid. No signs of cephalopelvic disproportion. So what you will do in this case, you will go room. Okay? This will go room. And this is the only difference between the two algorithms. Okay? When to consider transfer to theta? When a station is 0 or +1. And rotation is required. Or feature suspicious of cephalopelvic disproportion. Okay? Or that you need neuroaxial anesthesia. Clear, my friends? Okay. So here, our case, para 1, admitted in labor, fully dilated, 2 hours, examined and found to be fully dilated, left occipital anterior, okay? So it's not even an occipitoposterior or transverse or anything. Vertex 1 cm below spine and plus only one caput and no molding. So this can be done in the room. Okay, my friends? As I told you, this is a tiny difference in the guideline. Okay. Another one, 30-year-old primey at 41 weeks of gestation, and she had a amniotomy for confirmed delay in the first stage of labor at 6 cm dilated. Okay? So amniotomy, confirmed delay at 6 cm dilated. Now she's contracting 3 times in 10 minutes. What you will do after amniotomy? What you will do after amniotomy? Examination in 2 hours. Yes, exactly. Well done. Are we clear, everyone? Good. So here, another scenario. A 25-year primey, she had a vaginal examination at 1 p.m. where she was found to be 6 cm dilated. Left occipito posterior position. Vertex 3 cm above spine with plus caput and no molding. She's commenced on oxytocin for confirmed delay in the first stage of labor. She is re-examined at 4 p.m. and found to be 7 cm dilated. Okay? So we started with what? We started with 6 cm. After the oxytocin, she is now 7 cm. Left occipito posterior, vertex 2 cm above spine, 2 plus caput plus molding. So what do you think? Yes, so this is a confirmed delay, non-progressive labor. And with the 2 caput, 2 plus caput, 1 plus molding, I am suspecting here cephalopelvic disproportion. So what I will do? I will go for cesarean now, right? The question here, my friend, which category is this cesarean? This is category 1 or category 2? So for non-progressive labor, this will be category 1 cesarean or category 2 cesarean. It's category 2. Yes, category 2. Well done. I am happy. Even every one of you said it correctly. Good. So non-progress is category 2, and for cases who have serious condition like abnormal CTG or suspicious CTG with quarter prolapse, you have like tender scar, you have a pathological CTG while the baby is not in a good position, plus the non-progress. So in those cases, abruption, yes, then you would go for the category 1 for this case, because category 1 is to save maternal or fetal life, right? And you need to do this in less than 30 minutes. So well done, my friends. A 36-year-old para 1 transferred to labor room from the community midwife at 8 cm dilatation following a spontaneous rupture of membrane found to have grade 3 meconium. So meconium is a reason for transfer, yes or no? Yes, of course. Meconium is a reason to start continuous CTG, yes or no? Yes, it is. Well done. And it's considered as a risk factor, remember. Okay, so if you have a suspicious CTG with meconium, you can consider expediting birth. Okay, so here on admission to labor room, she had an urge to push. Good. So when she was, transferred, it's been transferred, she become fully dilated and there is urge to push. On examination, presenting part is crowning now. Good. The fetal heart, bradycardia, 80 to 90 for 4 minutes. So you need to deliver fast. She does not deliver over the next two contractions. So what you will do? Okay, so what is the, yes, what is the instrument of choice if you wanted to perform an instrumental delivery? This will be the forceps, okay? But I'll tell you, my dear friends, when the head is at crowning and you want to perform, right, a forceps delivery, would you consider episiotomy first, yes or no? What do you think? So when he tell you head is crowning, right? And she does not deliver over the next two contractions, what you will do first? Episiotomy first or forceps first? It's a known trick. This is the thing. It's not like I'm super smart. No, it's not like this at all. Just because this question is a tricky question and it's repeated tricky. It was a strategy and then appeared in some books, appeared in the exam. So yes. So it will be in this case the episiotomy first. Yes. Okay. Because episiotomy in the options. You know, my friends, if I have 5 options, okay, between, for example, like those options only, no episiotomy in there, an instrumental delivery in the room, or outlet forceps, or even kiwi vacuum, I will go for this because this is the best available. Okay. But let's say episiotomy is there. So episiotomy will be more suitable and more practical, especially that he told you that the already head is crowning. So this is the time practically where we will perform the episiotomy, right? Yes. Well done. Okay. So you were correct in the thinking that I need to do outlet forceps or a vacuum, right? At this stage. But practically, if you compare between the episiotomy and the outlet delivery, assisted vaginal birth, you will find that episiotomy is the first thing to do. Okay. Yes, good. No problem, my dear. See, I'll tell you something that's very important. You know what it is? That the few days before exam, okay, alhamdulillah, that Allah subhanahu wa ta'ala give us this ability. So the human brain is a wonderful, piece of art by Allah subhanahu wa ta'ala. So you will find that your concentration is doubled, right? And you will find your memory is more sharp, inshallah, and it will make a different, very good difference in your exam. Okay, so don't worry. Okay, this is now the best time to think about details, right? And to change your perspective for the exam. There's no problem, it's not too late. This is a very good time. And this is the time where you you know, polish your information, you refine your way of approaching the questions. Okay, so just calm down, and be confident. Inshallah, you will not fall into any trap in the exam. Okay, the most important thing that you not let your nerves fails you. This is what I'm saying always, because stress, doubt, okay, is your enemy in the exam, not the questions, not the examiner. It's stress and doubt. Okay, inshallah. So let's see this one. 25-year-old, 40 weeks pregnant, in her first pregnancy, in the second stage of labor. So she's preemie, 40 weeks, actively pushing for 2 hours and exhausted. So we need to do something. CTG show baseline of 150. What do you think about this CTG? Okay, normal baseline variability, occasional acceleration, and infrequent typical variable deceleration. So accelerations are there, so I am happy. Variable deceleration are there, but they are typical and infrequent, so no problem. Yes, acceptable. She is contracting 3 to 4 every 10 minutes. Contraction also is fine. General examination reveal fully dilated cervix and fetal head in a direct occipital anterior position. And station 1 plus below spine. Which of the following is most appropriate next step? Yes, exactly. Well done. So I will need to give her a trial of instrumental delivery. Right? Good. And 25-year-old, 40 weeks in her first pregnancy, is in second stage of labor. She has been actively pushing for 1 hour. Okay? So, pushing for 1 hour, let's see. CTG baseline of 180. What do you think this CTG is? Pathological now, right? Reduced baseline variability. No acceleration and frequent atypical variable deceleration. So this is the opposite of the previous one. This is a bad CTG. She's contracting 3 to 4 every 10 minutes. And vaginal examination reveals full dilated cervix with fetal head in the direct occipital anterior position and station 1 plus below spine. Which of the following is most appropriate next step of management? So this is a pathological CTG, right? And you have cesarean delivery. This is an option. No, of course no. Okay? Episiotomy. Now? No. Fetal blood sampling. Would you do it? No. Instrumental delivery. Yes. Oxytocin, of course, no. Yes, exactly. Well done. You are counseling with the bad CTG? Yes, you can consider it, of course. Pathological CTG, you can consider it in the OT. And she's primary. So you are counseling a 28-year-old primary with a single-tone pregnancy at the antenatal clinic at 38 weeks. So this is only counseling. For options of delivery, the clinical history, normal, and perceiving good fetal movement, alhamdulillah. And she had a fetus in the cephalic presentation. Which of the following statement is incorrect? Be careful of incorrect in the exam or except. What do you think? Induction of labor, Irish guideline. Okay. So the question here, my friend, can I offer a membranous sweep for this patient at 38 weeks? When shall I do the induction of labor? What is the right time to offer her an induction of labor? "41." Yes. Okay, good. Is there a risk in this case to advise her for the induction of labor at 40? Okay. So when can you consider the membranous sweep even if the woman wants so? From 39, right? Is that correct? Yes, good. So I'm so happy. Why? Because you are very good in the concept. Really, alhamdulillah. So here, my friends, yes, the membranous sweep. Yes, okay. So look, my friends, membranous sweep can be offered as it reduces the need for induction of labor. This is one sentence. If she does not sit into spontaneous labor, she will be offered induction at labor at 40. This is another sentence. So, what do you think the best out of them? B. Okay, yes. I will go for B. Yes, exactly. Okay? I'll tell you. No, no, no. Look, my dear. Yes. Look, my dear. Okay? So, this patient, whenever we have a patient that she did not progress at her time, at her due time, Okay, at that time, we can discuss with her, even if she's a low risk, the induction of labor. We can even start the process by the membrane sweep. Okay, once she is post dated, because she reached 40 weeks, she is post dated. Okay, so I can here at that time discuss with her the induction of labor, but it will take some time till we prepare it because induction of labor is elective process. So there are some steps that I can do. Okay, right? So if she does not sit into spontaneous labor, she will be offered. At that time, I will offer her the induction of labor at the time of the 40 weeks. Okay, but I can start the process by counseling or offering her, discuss with her pros and cons. I can make like a membrane sweep at that time, right? And prepare her and book her for a day for the induction of labor, right? Okay, because this is D, Dr. Ahmed. If one attempt of induction fails, another attempt may be made. We don't know what is the outcome of the first induction. Okay, so this is like non-specific sentence. I'll tell you, here I don't have a perfect option. In this question, I don't have a perfect option. And this is what you will face in some questions in the exam. Let's be clear about it. Sometimes the options are not perfect. Okay, so you will go to the most correct one. Okay, not the best, the nearest to the correct. Okay, so I can see here no perfect option because it should write that if she didn't go for the spontaneous labor, okay, I will offer the induction at 40 weeks, right? Yes, we all know that induction should be offered from, or I will do it at the time, or I will form from 41 plus, right? But I don't have any other option that can work. But if you think about it, okay, if the patient is brimy and 40 weeks, I can consider, right, for her the induction of labor at 40 weeks. Okay, other options, because in exam also sometimes we solve by exclusion, right? Other options are not suitable at all. So next question here also about induction of labor. So induction of labor should not be offered if has anybody noticed that the previous question says that which option is incorrect? Yes, my voice is here. I'm trying. Hello, 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 hello. Can you hear me? Okay, so which option you will choose? I'm sorry, I'm just trying to find the plug because it's going to power off. Okay, so you will not offer it to C. Good. Good. So see another one. While counseling a low-risk primary about planning of her delivery, what information should be given to her? Do you think that A is correct? Home birth or midwifery led unit freestanding or alongside is not particularly suitable? No, of course, this is wrong. Small increase in the risk of adverse outcome to her baby exists if she plans to deliver at home. What do you think? Small increase in risk of adverse outcome. Okay, so can be one option. Okay, let's see if there is any other option. An admission CTG will be performed if she is admitted to labor with suspected but not established labor. Will you do admission CTG? Yes or no? No. She must not ask for the cord to be cut later than 5 minutes after delivery. The success rate of vaginal delivery in midwifery-led units due to timely and a higher rate of intervention. Is that higher rate of intervention in the midwifery? No, higher rate of intervention in the obstetric. Okay, so now which answer is the best? Yes, there is a small increase in risk of adverse outcome to her baby if she planned to deliver at home. Yes, this is the one. Okay. The previous question, Dr. iPad. Induction of labor should not be offered if what? Yes, A is there. Okay. Okay. But one would be like a contraindication and one could be done with exception. Okay. Hello, Dr. Ambreen. How are you? Okay. So, which one you will not ever think of offering here? Which one you will never offer? It's C. because the lady she have, yes, the lady she have severe IUGR baby with suspicious CTG. Can I perform ever induction of labor with suspicious CTG? No, never, right? So this is like an absolute contraindication for induction of labor. Suspicious CTG, right, itself is absolutely no. But reduced amniotic fluid is one of the things that will increase risk of induction. Severe FGR, also, we will not stress the baby already, right? So, not this one. How about A? A, this is a multipara. So, multipara is okay. Let's see. She is breech. ECV failed and she want only vaginal delivery. So, when to consider induction of labor for a patient who had breech? This is if the patient, she had failed the ECV and in the same time she refused cesarean section. Okay? So it's not contraindication in the breech, my dear Dr. Amna. Induction of labor, we don't usually recommend, but it's not a contraindication. Okay? When it is the only thing in front of us, in a case of breech, you can consider the induction of labor. Right? It's like the augmentation by oxytocin. Usually we don't do it routinely, but in some cases we can do augmentation, right? So not routinely recommended is different from contraindicated, right? So I wouldn't prefer A. Nobody prefer induction for the breech, but can I consider it if it's the only option? Yes, I can consider it. But here, see, nobody will do this. Nobody will perform induction of labor on a suspicious CTG. Clear, my dears? Okay, welcome. So here, which of the following is recommended as a method of induction of labor? So Irish guideline for the induction of labor, right? Either you use ProPress, right? 10 mg vaginal delivery system, or you will do Prostine E2 vaginal gel, right? Okay, so here, my friends, let's have a quick look on that algorithm. And this is the algorithm number 1 of the induction of labor. Here, you will have for the induction of labor pathway for a woman with no contraindication an intact membrane using Prostine E2 vaginal gel. Record the history, note risk factor, conduct vaginal examination. If the Bishop score less than 7, and by the way, you have to revise the Bishop score for the exam. Okay? Normal CTG, no regular contraction. So what you will do if less than 7? I can consider repeating the Prostin gel, but it for multipara, I will repeat 1. For primary, I will insert, repeat 2. Okay, so for primary and the patient score less than 7, what you will do, 2 pm, 2 mg, sorry, Prostin. Multipara, insert 1 mg Prostin. Then perform a CTG for 30 minutes after the prostaglandin vaginal examination after 6 hours, unless clinically indicated. So this can be side of the exam questions. Many questions can come from this part. First is induction. right? Which method of induction or which agent for the induction? We have prostein, E2, right? And then you will perform the vaginal examination. If the vaginal examination show that the bishop score less than 7, normal CTG, no regular contraction, I will use 2 mg prostein for primary. I will use 1 mg prostein for multi. Okay? And then what method of the monitoring CTG? Is it continuous? Tell me, my friend, continuous? No, she will not set for all the time, right? It will be starting CTG only. 30 minutes. If it is okay, stop it, right? Good. And when is the next vaginal examination? Not 4 hours, not 2 hours, it's 6 hours. Okay? Unless clinically indicated. Means that, like, for example, she come to you and she says that there is something came out or she feel the contractions are strong or something like this. Otherwise, keep her for 6 hours. Okay, so at 6 hours, you examined her and you found that the bishop score is now good, more than 7. What you will do to continue the induction if the bishop score is more than 7? Of course, in your exam, they will not tell you bishop score becomes 7. In the exam, they will give you the finding, the vaginal finding, and ask you to do what? To take the decision. So that means you will have to calculate the bishop score yourself. Okay? Yes. So perform the amniotomy after bishop score more than 7. You will choose amniotomy. And this is a previous exam question already in March. If amniotomy not possible, then the bishop score less than 7, no contraindication. What you will do? Administer a further 1 mg prostein. Another one of 1 mg prostein. Okay? So the second dose is what? Is 1 mg prostein. Can give 1 mg every 6 hours, up to 4 for primary and 3 for multi. So repeat again with me. Second dose after assessment of 6 hours is now 1 mg for both primary or for multi. What is the difference? The difference is that I can repeat up to 4 mg in cases of primaries and repeat only up to 3 in multi. So 6 hours. So let's say I have primary. Then bishop score is less than 7. Started with 2 mg prostein. After 6 hours, what happened is still the same. 1 mg prostein. Then I can repeat and so on. Okay? So this will be up every 6 hours up to 4 for Brian. Okay? Good. Well done. Induction of labor with intact membrane using ProPress 10 mg. Okay? Same recommendation. But here, if bishop score less than 7, insert the ProPress into the posterior fornix. CTG, how many minutes? 30 minutes. Vaginal examination after 2 hours, unless clinically indicated. After 24 hours. So be careful which agent is.
جاي اجيب الايباد واجي
Can I
جاي
can I
جاي
can I just repeat it, my friends? What do you think? after the progress vaginal system, which is done for 24 hours, you will assess the Bishop score less than 7. You will administer a prostate, okay, 1 mg prostate, and then reassess after 6 hours, okay? And this is one time only prostate. If it's still Bishop less than 6 hours, so now consultant opinion, okay? Okay, my friends. So I'm not repeating the ProPress system because the ProPress system is working for 24 hours. So one time only is enough. If I need to give like additional push, I can try one additional protein. That's it. Okay. Clear, my friends? The part that they love to ask. Okay. VBAC, vaginal examination. Bishop score 7 or more. What to do? Amniotomy, plus or minus oxytocin. Bishop score less than 7. What you will offer? They like this question. A VBAC in the exam with induction of labor. What is the best method? Prostate or the progressed vaginal system or mechanical? Mechanical, of course. Yes, exactly. Okay. So in the form of a balloon, catheter, or osmotic cervical dilator. And then after this, you will check. Okay. What will be the next? It will be ARM plus or minus oxytocin. And if it's not suitable or not possible ARM, then perform category 3 cesarean section. But don't insert prostaglandin. Clear, my friends? Good. Last one. Last one. No problem, my dear, because she's already prom. Okay? You will not insert prostaglandin. Either she will go naturally or you will take her for cesarean section category 3. Okay? So let's say the lady came to you. She is prom, right? And now you wanted to check whether she will go for delivery or no. Okay? If the os is closed and still amniotomy, give a chance and see what will happen. Right? Good. So induction of labor pathway for a woman with pre-labor rupture of membrane. This is term, not a preterm, from 37 weeks. Assess the CTG and Lycor color. Obstetric review if you have CTG concern, meconium or blood-stained Lycor or other clinical concern. If the woman is GBS carrier, you will do induction of labor at the time and offer antibiotic prophylaxis. But if not a GBS carrier or unknown, just a low-risk case and she is 38 weeks, for example, and she have rupture of membrane, consider immediate induction of labor or induction of labor after 24 hours. Assess for water. Consider prostate 1 to 2 mg if the Bishop score less than 7, taking parity and the clinical scenario into consideration. So here, if rupture of membrane already and 24 hours passed, okay, and still Bishop score is not good, I can consider prostate one time, okay, according to the gravida or the clinical assessment. Okay, so this is for the induction of labor after rupture of membrane. I need to say one trick here, okay, that sometimes he give you a case. She's 37 weeks plus or 39, and she had induction of labor. sorry, rupture of membrane. And in the options, there is only one suitable option, or one option says, consider immediate induction of labor. Can this be a correct answer? No wait for 24 hours is available. So you don't have option to wait for 24 hours. Can this be the best answer? Yes, sure, doctor, I will revise the Bishop score. Can this be the best answer? Yes, can be a best answer. Okay, so this is a trick, because everybody thinking that rupture of membrane at term, so wait for 24 hour only. No, I can consider immediate. If the lady doesn't want to wait, okay, so we will counsel her regarding the induction of labor and everything. If she's happy to go for it, go for it. No problem. Okay. We always give the patient options, right? And if, of course, clinically, we do that once you have, available bed and available place, so we can go for the induction of labor. So don't strictly refuse the induction of labor. Okay? Okay. So this is, my friend, for the 1 second, because I have to answer the one question asking induction of labor for a case of VBAC, right? What shall I do for it? When to do it, right? So I will do it at normal time, okay, of offering the induction of labor. One second. I just want to open the Bishop score. Bismillah. I will revise, guys, with you the Bishop score. Okay, and you have to able to calculate it in the exam. Okay. Yes, of course, you can ask a question. Why not, my dear? Ask whatever you want.
Good morning دكتورة رابعة.
Good morning, حبيبتي.
دكتورة بالنسبة للميكانيكال اندكشن للفي باك at what gestation؟
It's at the normal time when you offer the induction of labor. So
41.
41. But for
Okay.
example, if I have an obese woman, when you will offer?
Obese woman? I don't know.
You will do it early.
Okay.
No problem. No problem. You will do it at 40 minutes.
IUFD طيب.
Yes. Previous case of IUFD, you will consider also early.
Okay.
So we will revise the timing of the induction of labor. Okay.
Okay. Okay.
Okay.
Thank you.
You're welcome, my dear. الله يوفقك يا رب. بسم الله. I think we go for timing first, quickly, and then we go for the bishop to make sense of our discussion. Okay. So my friends, from the beginning, when to offer the induction of labor. Okay. If the uncomplicated pregnancy, you can offer the induction of labor at 41 weeks, right? After discussion with the woman about risk and benefit and everything. And if the woman decline the induction, which is a very common exam question, right? For the prevention of prolonged pregnancy, she need to see a senior clinician, right? And then you will put a plan for her, right? So we will recommend ultrasound estimation of the amniotic fluid, single deepest pool, to be undertaken at this visit and at 41 weeks, okay? And then if she passed 42 weeks, what you will do? You will discuss with her the options, right? And you will counsel her about the risk of stillbirth, okay? But you will increase the monitoring. This is a very common exam question. If the woman decline the induction, you will increase the monitoring in the form of twice weekly CTG and twice weekly ultrasound estimation of amniotic fluid, single deepest pool, okay? And this is, if this is beyond what? If this is beyond 42 weeks until the baby is born, okay? So twice per week if she decline induction. Okay. So here, for the women who have a pre-labor rupture of membrane at term, when you will offer the induction, you will wait for 24 hours or immediate, according to the woman needs and according to the situation. Okay, so this is a shared decision making. So again, in the immediate induction of labor at 24 weeks is not wrong option, because again, it was a question in the exam. We recommended that women with pre-labor rupture of membrane who have known GBS should be offered the prompt intrapartum antibiotic prophylaxis and induction of labor, because the risk of the group B streptococcus. Once group B streptococcus carrier is identified, immediate induction and intrapartum antibiotics. So this is also another exam question. So for the setting of pre-labor rupture of membrane and unfavorable cervix, score less than 7, you remember, okay? So what you will do, if pre-labor rupture of membrane and unfavorable cervix, what you will do, remember, prostein will be given 1 to 2. Shall I repeat? A case already rupture of membrane, and she did not progress into labor. Bishop score is not good despite waiting, and I wanted to induce her. What is the dose of induction? One single prostein, either 1 or 2 according to parity, okay? Prostein gel inserted in the posterior fornix. Okay, my friends, be careful of this point. She had already rupture of membrane. How many prostein gel to give? Single, don't repeat. If she already known to have rupture of membrane first. Yes, exactly, Dr. Abir. Well done. We recommended that in setting of pre-labor rupture of membrane, vaginal examination should be performed, right? To confirm the four water are absent, and or an amniotomy should be performed if the four water are still present before commencing oxytocin infusion. Right? Good. The woman who have risk of uterine rupture should be counseled regarding the induction of labor. Okay? So if she had a previous uterine surgery, such as myomectomy or a VBAC, myomectomy or a VBAC, in your exam, they love the example of myomectomy. She had a previous myomectomy. So what you will do, or previous uterine perforation, then should be offer, right, a mechanical method, okay? Or if she have favorable cervix, you will go by a amniotomy straight away. When you will do that? at the normal time of induction of labor. So you will see her once before 41 weeks, okay? A review aiming for vaginal birth after cesarean should be undertaken before 41 weeks to assess the cervix and reconsider the option, okay? Not at 39 weeks, my dear. Why you will induce her at 39 weeks? This, the woman, look, my dear, if I have a high risk, I will consider early. What is the high risk? Not high risk because she's a VBAC, not obstetric high risk. No, I mean high risk for maternal reason. Put the baby at high risk of stillbirth. So that's what I will deliver earlier. Yes, like reduce the fetal membrane, of course, reduce the fetal movement, sorry. This is an indication, of course, of induction at any time. Severe IUGR, abnormal Doppler, mother is diabetic and complicated, right? So all the indications that you know it in the high-risk pregnancy for early delivery, aiming to reduce the risk of stillbirth. So if the baby is at risk of stillbirth, okay, then you will deliver early. But VBAC is obstetric risk. Mother is the risk of rupture of membrane, okay? So it does not depend on the age of the delivery, the gestational age, it depends on the method of induction. And to be honest, it's better to leave her for normal onset of labor and avoid the induction if she had a previous surgery. But reached 41 weeks, like any other woman, I am afraid now of the increased chances of stillbirth, so I will induce her at 41. You got the point, guys? So I don't need to deliver earlier because only she had a previous uterine surgery. When to consider earlier delivery? This is important. Let's say she doesn't have any medical problem, like not preeclampsia, nothing, okay? I will consider or over induction of labor at 39 to 40 weeks for a woman who age 40. And the age 40 is at risk of what? Baby is at risk of stillbirth because mother is 40 or above, right? In the very advanced maternal age, we even consider it from 38. Yes, that's because of risk of placental insufficiency. Okay? In the suspected macrosomia, in absence of gestational diabetes, offer induction of labor, okay? And this will be by informed decision. So even in macrosomia, absence of diabetes, I don't have a reason for early, but I will discuss about the induction benefit and risk. Okay? Now, for women who request of induction. So the woman, she want induction of labor for any reason. Okay? Partner is traveling, partner is going to war, anything. Okay? So request of induction of labor, when I will consider it at 37 weeks, what do you think? A woman comes to you and requests induction of labor. No. 38 weeks? No. From 39 weeks, I can allow her to have induction of labor because I will do no harm to the baby. Okay? Wait till full term, till 39. Okay? Okay? So don't do induction of labor for maternal request before 39 weeks. Okay? And there is no sufficient evidence also, right? Even to induce at 39 in normal risk pregnancy for prevention of stillbirth. If high risk pregnancy, yes. Normal risk, no. Not at 39, as everyone else at 41. Okay, my friends? Clear the timing of the when you will advise the induction of labor for each one? Okay? Are we clear about the VBAC? Should be in the normal time? Okay, good. Alhamdulillah. So here, my friends, for the modified Bishop score, okay, he will give you in the exam, like the CTG, okay? What he will give you? He will give you finding, okay? And you will have to calculate and you have to take your decision. Okay, you're welcome, my dear. No need to thank you, alhamdulillah. Okay, so what you will do, my friends, you will see. He will tell you cervical dilatation. He will tell you consistency of the cervix. He will tell you the position of the cervix. Either it's central, either it's posterior, okay? Either the cervix become anterior, okay? So the finding, each finding will have a score. So he will tell you also the dilatation. He will tell you the fetal head position. Okay, so this is the main thing that you need to consider in the modified Bishop score, right? So let's see. I want to use the simplest one. Bismillah. I'm sorry, I'm trying wallahi to bring another one with no hazy, but inshallah I will find another one. Okay, so you give a score of what, my dear friends? You will give a score of 0 to 1 to 2 or even 3. Use for every item, okay? If he told you that the cervix is closed, so which score is that? Closed, permanent. So will you give any score for closed? No. Okay, so if the cervix is closed, nothing. Good. If the cervix is 1 to 2 cm dilated, 1 to 2 cm dilated is better. So give a score 1. Okay? If the cervix 3 to 4 cm, this is a score 2. Okay, good. How about cervical effacement? Effacement is very important. Consider the effacement 0 to 30% is score 0. 40 to 50% effacement, this is score 1. 60 to 70%, this is score 2. What if I told you 80% effacement? This is very good. This is score 3. How about the station of the baby, baby head? So if the baby, for example, is very high, -3, so this is still high head, not engaged even. So 0, -2, give 1. At 0 station or -1, so this is score 2. This is when I allow the instrumental delivery. +1 or 2 plus, this is score 3. So this is a very good finding. Cervical position. The best one is anterior position, and this is will take a score 2. Middle line, okay, this is, or central, this is 1. Cervical position posterior, so give 0 for posterior. Okay, consistency. The best consistency is the soft. So when it is firm, it is 0. When it is moderately firm, it is 1. When it is soft or ripened cervix, this is 2. So my dear, I'll tell you cases and you tell me. Okay, so we will score it together. A patient, right, came for induction of labor and you are performing assessment before insertion of the prostate. Okay, you find that her cervix is closed. Count with me, please. 20% effaced. Baby head at 0 station. And the cervix is central. Consistency is firm. So what is the finding now? 0, 0, 2, 1, 0. So this is total 3. Right? Good. You inserted the prostate. When is the next vaginal examination? After 6 hours. Well done. Okay? So next vaginal examination after 6 hours, you repeated the examination. You found that cervix is 2 cm. 50% effaced. Baby head at 0. But it become anterior. And it's moderately firm. So 1, 1, 2, 2, and yes, it's now 7. What you will do? What is the action? ARM. Well done. Another patient, after she had the ProPress system for 24 hours, you repeated her examination. You found that her cervix is 1 cm dilated, 50% effaced, baby head at -1, but the cervical position is posterior. Consistency is firm. So what is the score? In exam, he will not ask you score. This is 1, 1, 2, 0, 0, so 4. What is the action? This is the exam question. What is the action? Because now score less than 7, I will do a prostate. How many prostate are allowed in this case? 1 time, single. Yes, exactly. Well done. Okay? So, please revise the Bishop score for the exam. Okay? Because you will need it. Inshallah, you will need it. Okay? And when you find the question, you will be very happy. Inshallah. Okay? So, Ya Rab, inshallah, you will be very happy. Inshallah. You have done a very beautiful job so far, my friends. Just continue, push yourself. Okay? It's like 48 hours, and inshallah, you will finish and you will relax. Inshallah. Okay, so just a few questions are remaining in our morning session, and I will have to say goodbye because I have work to go. Okay? Please can repeat it single dose. If you use a ProPress and after 24 hours, still cervix is not favorable, Bishop score less than 7, you will give a single dose of prostate, okay? Not allowed to repeat. But if you use a prostate as a primary agent and it's still not good, and you give prostate again, you are allowed up to 4 hours in 4 doses in primary and 3 mg in multi. Okay? Because if you just calculate it, you find that the woman passed the 24 hours of induction. Yes. So my friends, here, in 32 years old, grab the 2 para 1 multi, transferred from the midwifery unit, lack of progress at 4 cm. Previous baby was 3, 1, okay? And she delivered normally at 38. On admission, observation normal, CTG reassuring, midwife examined her, diagnosed complete breech, and is confirmed on scan. The woman is very keen to have vaginal delivery, and decision has been taken to allow her to continue. After 2 hours, no progress in labor, and the CTG becomes suspicious. So what is the appropriate action? Can I give syntocinon on suspicious CTG? No. Can I just continue observation for 1 hour? Like nothing has happened? Can I do this? No. ECV in labor with bad CTG? No. Fetal blood sampling? No, not allowed, of course. Okay, so the only thing is advise emergency cesarean section. Okay, my friends? Which category is that of cesarean section? That's category 2. Well done. Well done. This is another one. 42-year-old, 39 weeks of gestation. In the second pregnancy, she's having prior emergency cesarean section for fetal distress 3 years earlier. She's keen to give birth vaginally, but requesting induction of labor because of concern regarding increased risk of perinatal mortality associated with her age, because she is at 42. Okay, so what is the most appropriate method of induction to minimize the risk of uterine rupture? Yes, well done. So the best is transcervical Foley catheter. Yes, well done, alhamdulillah. Okay. A low risk 34-year-old in her second pregnancy admitted in spontaneous labor at 39 weeks of gestation. Cervix is effaced and 5 cm dilated with membranes intact on admission. She's examined again 4 hours later and she's 6 cm dilated. She consents for ARM. Lycor is clear. What is the most appropriate method of fetal monitoring? Look, my friends. So now, okay, she had amniotomy, right? Amniotomy is not an indication for continuous CTG, but now, 1 second, my friends. Now, after amniotomy, what should be the action? Remember, after amniotomy now, do I need to check by a CTG for a short time? Yes, you check for a short time if everything is fine, okay? What you will do? You will continue the observation, right? Okay. After prostene gel, what you need to do after a prostene gel? For how long you will continue the CTG? Continuous or just 30 minutes? Yes. for 30 minutes. Well done. Well done, my friends. Okay. So now, a short time of CTG and then back to the intermittent auscultation. Okay? Okay, so last question today, and then you are free to go. What is the low limit of gestational age for the use of vacuum extractor? What do you think? Lower age? 34 or 32? What do you think? Between 32 to 36. Use with? Use with caution, right? Can I still use it, Dr. Ahmed? Can I still use it with caution? Yes or no? It's very important that we differentiate between the preferred perfect time, okay, and the time where it is contraindicated, right? So what is the preferred time, or what is the safe time? When to consider it that this is a safe practice? Anybody can do it. Anybody who's trained, of course, on it can do it. Yes, this is from 36 weeks. 36 weeks is a safe practice, okay? But is it contraindicated before 36 weeks or not allowed? No, I can use it before the 36 weeks, but with caution. With what, my friends? With caution, right? Okay, so I will use it with caution, starting from which gestation? Because there was old recommendation, and this old recommendation now has changed. Old recommendation was 34, now it changed. Now it changed to 32. Okay? Now has it changed to 32. Guys, look, my friend, here in the very beginning of the recommendation of the guideline, the 2025, vacuum assisted birth should be avoided below 32 weeks of gestation and need experienced clinician between 32 and 36. Clear, my friend? So forget the 34. 34, it was the old recommendation. Okay? It is allowed from 32 to 36 with caution. So experienced clinician only, like a consultant, can do it. But before 32, no. After 36 is safe. Is it clear, my friends? Okay, so this is a good note, okay, that my friends, you take care of it, because this is a very easy question and expected to appear, of course, in your exam. I would like to thank you very much for today. Okay, inshallah, today after iftar, I will send you questions on the group. Okay, we will practice some questions, a group discussion, okay? But will be at night, inshallah, after Isha prayer, okay? And tomorrow, inshallah, at 10 a.m. GMT, we will meet again, okay? Thank you very much, my dear. Alhamdulillah, that we are clearing doubt, alhamdulillah, okay? Inshallah, your exam is going to be easy and will be clear. And inshallah, ربنا سبحانه وتعالى يرزقكم الجواب الصحيح بإذن الله. السلام عليكم. باي باي.